In the hip preservation series, the next talk is by Dr. Mohammad Younus of Allahabad, who is going to talk about what was retro and now has become metro in hip preservation, IHO, or Ilizarov hip arthrodesis. Over to Dr. Mohammad Younus from Allahabad.
Hello everyone. It gives me immense pleasure to be interacting with so many enthusiastic orthopedic surgeons throughout the world via this webinar. I thank the organizers for this gracious invitation to this Golden Jubilee OSSAPCON 2021. I wish all the organizers and delegates all the very best for a very successful conference. The theme for today's CME, as we all know, is Retro to Metro, and the topic that we shall be discussing today will be an interesting addition in the form of an innovative, resourceful, offbeat method to deal with a very common orthopedic problem that we deal with every day around the hip region. And that is a little unconventional, little unorthodox, out of the box, but definitely will be beneficial to the patient, both in short term and long term. And this gives the best possible treatment outcome without resorting to expensive conventional orthopedic surgical methods. I am Dr. Mohammad Younus, and I am from Allahabad, the city famous for its confluence of Ganga and Yamuna, the holy rivers, and the land of Kumbh Mela. When dealing with the concept of retro to metro, it is easily overlooked that what is now called vintage was once very brand new. And cool is when vintage meets modern techniques. Assume a patient walks into our orthopedic OPD with such an X-ray. The average orthopedic surgeon will immediately think, now we have a patient for total hip replacement. That is the way an orthopedic mind works. That is the basic default method in which we work. We don't care much about what exactly is the diagnosis. We don't care exactly much about what will be the etiopathology in this thing. Ultimately, what we have is a destroyed hip, and what we want to offer him is a functional hip via a total hip replacement. But assume this patient, we are putting him down on the examination couch, and we find that there is a previous old operated surgical scar, or a previously healed infected scar, or a draining sinus now. Then the enthusiasm which we thought about total hip replacement, it comes down drastically. And this will particularly come down in such cases where destroyed hips, which are a result of septic sequelae. This is much more the case in completely destroyed head as a result of septic sequelae, or such destroyed hips, mortar and pestle acetabulum, and femoral head as a result of tuberculosis. Total hip replacement becomes particularly difficult in cases like this, with dysplasia of the acetabulum, with congenital dislocation of the hip. Again, all these cases are still managed by total hip replacement despite all the shortcomings, with advanced implants, with newer techniques. But we will be looking into easier method, more innovative method, a little bit more offbeat method. Obviously, it will be unorthodox for a orthoplasty surgeon, but it will be beneficial for the patient in the long run. Total hip replacement becomes particularly difficult in such gross COXA VARA. Whatever be the etiopathology, COXA VARA, it's a tough case for a primary total hip replacement. And these cases are best managed by the innovative method that we shall be dealing with in this today's topic. So before going into total hip replacement, we need to first understand, are we justifying total hip replacement in all these cases? This is the question which a surgeon should ask every time before offering the treatment modality to the patient. Is it the right indication? Will I be able to give the best possible result in this indication? And the most useful test for this is the Girdle stone test. Girdle stone test is a test which was advocated by Sir Charnley This is a test through which we have to put the patient before deciding about the total hip replacement. If your total hip replacement fails, what will be the worst possible outcome? You will have to remove the implant and you will have to leave it as a excisional arthroplasty or as a girdle stent arthroplasty. So will that outcome with just being a girdle stent, will it be better than the current clinical situation? Precisely, if the answer for this question is yes, then this patient passes the girdle stent test. If the girdle stent outcome is worse than the current clinical situation, then the patient does not pass the girdle stent test. It should not be offered to check. And the age of the patient is a very important criteria here. Younger the patient, we avoid ourselves from offering THR. And of course, the longevity of the implant is an important factor. With the current ceramic on ceramic linings and ceramic on highly cross-linked poly linings, we have more longevity of the implant, but still offering total hip replacement to young patients should be offered with caution. And does the local milieu has a say? Yes, obviously. If there was an old infection, whether healed or currently active, then the question of THR becomes less relevant. So we should first understand now from the philosophy of girdle stent test starts our concept of Ilizarov hip reconstruction. So what happens after girdle stent? After girdle stent, what we usually get is a near complete pain relief for the patient. And the patient has a near complete range of motion. And he has the ability to squat. This is a very important positive outcome from girdle stent arthroplasty as far as an Indian population is concerned. They want to squat, they want to sit cross-legged. So this is an important positive outcome. What are the negative outcomes here? The patient obviously gets relieved of the pain, but he has a Trendelenburg gait, the unstable gait. The abductor lever arm gets lost. Then shortening can be varying anywhere from 1.5 to 3 inches. And the limitation of abduction is another important issue here because of weakening of the abductor lever arm. Then there is also a hyperlordosis due to the flexion deformity of the hip that develops. And that will lead to some secondary effects on the spine. So if we develop a method that will combine all the positives of girdle stent, leaving out all the negatives of girdle stent, then that will be the best possible outcome. And the outcome will be competing with the outcome that we achieve by a total hip replacement. That is Ilizarov hip reconstruction. So what exactly do we do in Ilizarov hip reconstruction? We need to know first a forgotten concept of pelvic support osteotomy. I wouldn't say it exactly as forgotten concept, but still underused concept. It was proposed by various orthopedic surgeons throughout the history, by Lawrence, by Shands. We know of all these valgus osteotomies. And these osteotomies help in supporting the pelvis and annulling the Trendelenburg that gets developed after the excision arthroplasty. So here we are reinventing the same art of pelvic support osteotomy PSO by Ilizarov method, and this is Sir Abramovich Ilizarov, and we are offering the reinventing the lost art of PSO by Ilizarov methodology, and we call it Ilizarov hip reconstruction. IHR as an alternative for THR. Traditional PSO, pelvic support osteotomy, is a valgus osteotomy, but it happens only in the frontal plane. For example, you can see there's a valgus here fixed with a plate. It only happens in the frontal plane. You cannot do it in the sagittal plane. And there is the osteotomy can only be done at the intertrochanteric or subtrochanteric levels. It can't be done at any other level. The limb length discrepancy that results as a result of this dislocation is not addressed. LLD is not addressed. And the valgus that we achieve is very limited. We can't go for hypervalgus because excessive valgus will lead to excessive strain on the lateral compartment of the knee joint and the ankle joint, leading to secondary arthritis. So we are not characters of this novel Flatland, nor are we cartoon characters from this Marvel comic, Flatman. So we are three-dimensional people. So we need to offer a three-dimensional correction and not just a two-dimensional correction. That is called Ilizarov PSO, pelvic support osteotomy. So what are the indications? We can offer it in neonatal septic sequelae. You can offer it in pre-existing girdle stent arthroplasty. You can offer it in adolescent DDH. You can also offer in neuromuscular disorders like post-polio residual paralysis or triggered cord as a result of spina bifida. And practically speaking, it can be offered as a substitute for THR in any number of indications. The components of AHR are two. The first osteotomy is at the level of the ischial tuberosity, at the pelvic support region, and it is a hypervalgus osteotomy. The second osteotomy is much distal in the mid-cortical level, and that will lead to devulgarization as well as length correction. Let me explain them in detail. As a result of a dislocation or an excision arthroplasty, what happens is the head migrates upwards. You can see the abductor lever arm is shortened, so the patient is at a disadvantage, and that will lead to the development of unstable gait, namely the Trendelenburg gait. So what we offer is an extreme valgus that will lengthen the lever arm, giving a mechanical advantage for the abductor lever arm, and also in the sagittal plane we will get an extension, and in the transverse plane we get an internal rotation. These three components are essential in a proximal osteotomy. You can see the abductor lever arm is so small here, and once the Ilizarov PSO is done, the abductor lever arm is prolonged, the adductor muscles are prolonged, and obviously we're giving a mechanical advantage for the patient. This door, the carpenter would obviously fix the door knob in this region, not in point A, not in point B, not in point. It's best to have it in point C. We should never have it in point A. A traditional PSO shifts the lever arm from A to B, whereas an Ilizarov PSO goes all the way up to C. That is the advantage of an Ilizarov PSO. So what about the distal osteotomy? The distal osteotomy, as I said, is a mid-diaphyseal osteotomy. Its level is very important. The planning has to be done very critically. I will tell you exactly how it's done. And what exactly do we do in that osteotomy? We do lengthening of that osteotomy, and we do devulgazation later. We get excess valgus in the top, in the proximal osteotomy, and that is slightly devulgazed in the distal osteotomy, so that the mechanical axis is not medialized. It is brought back to the usual position, so that there is no excessive pressure on the lateral compartment of the knee and the ankle joint. So what about the preoperative planning? In the preoperative planning, we either do a weight-bearing X-ray or a hyper-adduction X-ray. You adduct the involved limb onto the normal limb and mark the level at which the femoral axis intersects the ischial tuberosity. This should also be done on the table with the hyper-adducted limb. And the second level of osteotomy is measured at the level of the mid-diaphysis. I'll tell you exactly how it is done. Assume that we have a 50 degree of adduction as a result of maximum adduction from on the opposite side of the limb. What we do is we add a 15 degree to it. I'll tell you why exactly we do the 15 degrees of addition later. So 50 plus 15, it is 65 degrees. So what we do is a 65 degree of valgus here, which is impossible to achieve by a traditional method using plates or any other internal fixation. So in Ilizarov, sky is the limit, and here we are limiting ourselves to 65 degrees. Then, once that 65 degree is done, you can see that the distal mechanical axis, the blue line, is going outwards. It is going away from the proximal mechanical axis, the red line. So this is the excess 15 degree that we were talking about. Once we start lengthening in the distal osteotomy, we do a devulgus. We bring it inwards and make it straight with the mechanical axis, so that there is no excessive pressure on both medial and lateral compartments. It is equally shared between both the compartments of the knee joint. So about Ilizarov hip reconstruction, the first person who actually did it was Sir Abramovich Ilizarov himself. So straight from the horse's mouth, if you want to know how exactly did Sir Ilizarov did his IHR, these are the drawings from his textbook of various levels, so supratrochanteric, transtrochanteric, subtrochanteric levels of IHR. These are the methodologies that he used. He used Russian arches, distal rings, and telescopic rods to achieve his results. Nowadays, we have much more easier arches, the Italian arches, which were popularized by the European Ilizarov surgeons, and we shall be using them more often than not. So preparation is very essential in an IHR. We have to have the armamentarium well. We should have the Russian arch. This is the Russian arch. This is the Italian arch. These are the usual Ilizarov rings, and the accessories are very important. So if you use the Russian arch, we'll be using only wires. So that is called the purist way. If you use the Italian arches, we'll be following the hybrid way. That is the mix of shank screws and wires. So in these two levels, I will move this. Yes. In these two levels, we'll be using arches, either Russian arch or Italian arch, and these arches are connected to subsequent levels with arch supports. This is how an arch support is connected to a distal ring. This is the right method of connecting because we distribute the forces of the arch throughout the ring in this manner. And this is the wrong method of connecting because all the forces are connected to the lateral aspect of the ring. This is the wrong method. When using all wire method, it's essential to have an olive wire from behind. These are all technical details for people who are interested in all wire proximal femur. But generally speaking, those who use shank screws in the proximal femur, this is not necessary. These are the rings that we use. You need to have the 5/8 rings, full rings in these levels and these levels. Whenever we do an Ilizarov femur frame, the cascade of the rings has to be maintained very well. It's all the rings coincide in a single level anteriorly, whereas the cascade is like this in the posterior aspect. And we should always try to get the distal femoral rings perpendicular to the mechanical axis of the femur and not parallel to the knee joint. That is another important issue that any surgeon needs to address. And the wire insertion technique has to be very careful so that the range of motion is preserved even after the insertion of the frame, and the proper results are ensured at the end of the day. Good knowledge of the neurovascular structures around the thigh is essential for an Ilizarov surgeon to do an Ilizarov femoral frame. These are the wires that we use, the normal wires, the olive wires, the shank screws. We can use tapered shank screws, we can use the normal cylindrical shank screws. The wires that we use are either bayonet tip or trocar tip according to the situation of the bone that we use. In cancellous bones, we use trocar tips, and in cortical bones, we use bayonet tips. And the shank screws are usually attached to the arches through these rancho cubes or wire fixation bolts. This is how a wire fixation bolt is attached according to the angle in which the shank screw meets the arch. My personal preference in Ilizarov hip reconstruction is like this. I have a Russian arch connected to an orphan ring, connected to a 5/8 ring. This is the distal femoral assembly. Over this, there will be another arch for the proximal femoral assembly. I'll get into the details in a short while. You can see this separate arch. This is for the proximal femur, and this combined arch with a ring with a 5/8 ring. This is for the distal femur. If I'm using Russian arch, I'll be using like this. This is the Russian arch connected to a full ring, to a 5/8 ring, and Russian arch connected proximally. This is very less often used only in tough situations. I'll come to specific cases later. So I feel that a partial prefabrication, this is called a prefabrication. We build the frame even before going into the surgery. So a partial prefabrication of the frame saves a lot of surgical time on the table under anesthesia. So what are the surgical steps? Here we have a dislocated hip or a excision arthroplasty case or a destroyed hip, whatever. Now what we do is first we adduct it, maximal adduction. Then take this limb across and we get the level of the ischial tuberosity. Probably the ischial tuberosity was at this level. So we'll be getting the proximal osteotomy at this level. So we first mark the level of the pelvis so that the pelvic tilt is addressed. And both anterior superior iliac spine or both posterior superior iliac spine are connected by an Ilizarov wire placed on the surface of the body and confirmed on the CM. And this is the connecting wire that is connecting the two anterior superior iliac spine. This wire is just placed on the surface of the limb just to mark the level of the both anterior superior iliac spines so that the pelvis is squared before going into the surgical steps. We pass one shank screw, two shank screw, all parallel to the floor. So you see these are all going at an angle to the diaphysis, but these are parallel to the floor of the surgical floor. And once this is done, what we do is the next step is we bring the leg back, and we already know the level of the ischial tuberosity at the maximum adduction. This was the level. Then we pass two shank screws at an angle that is little more than, that is around 15 degrees more, the usual 15 degrees that we had already planned, 15 degrees more than the exact orthogonal to the distal femoral axis. So we pass 2 shunt screws here, 2 or even you can pass 3. Then we do the osteotomy and make these 2. I'll go back to the previous step. You see these shunt screws are at different angles, and when you correct the osteotomy, what exactly happens is these 2 shunt screws become parallel and we achieve this amount of valgus, 65-degree of valgus. So what exactly we do then? We connect these shunt screws to an Italian arch, these shunt screws to an Italian arch, then connect them with threaded rods. Now we have a stable proximal femoral assembly. Now comes the distal femoral assembly. We use full rings, either 1 ring, 2 rings, 1 full ring, 1 pivot ring according to the situation. And we connect them with wires here instead of shunt screws, and we connect them with hinges so that we can give the patient lengthening. You can see this is the lengthening that we are offering. This is the level of the osteotomy, and this is the amount of lengthening that we achieve at this level. And D, this is the lengthening that you get. You see here, this is the amount of lengthening that we get. And the next step will be connecting 2 twisted plates on both sides and using this plate with a threaded rod, a lateral motor that will lead to valgus. You can see from here we push the leg like this. So now the mechanical axis of the proximal femur coincides with the mechanical axis of the distal femur. This is the exact principle of Ilizarov hip reconstruction. So how exactly do we do this? This is a 20-year-old male. This patient had a fracture neck of femur, and it unfortunately landed with an orthopedic surgeon who decided not to fix the neck of femur, and he decided to replace it with a bipolar hemiarthroplasty. Very unfortunate. I don't know the exact situation why the surgeon decided in the favor of bipolar hemiarthroplasty, but obviously this is not the right choice here. We should have tried to salvage the head as much as possible. And what happened after a few years, this bipolar cup kept eroding the acetabulum and it went into the protruding into the acetabulum as a protrusio. The patient was in severe pain, and the prosthesis was also infected, and now we are left with nothing other than removal of the prosthesis and leave it as a excision arthroplasty. This removal of this implant was not easy. We had to chew the poly on one side, dislocate the internal head, then remove the acetabular component separately, bipolar cup separately. And then we did the Ilizarov hip reconstruction. You can see these shunt screws have become parallel and these arches are now parallel. Now we get lengthening in this level and valgusization in this level. This is the first osteotomy. You can see the amount of valgus that we have got, around 65 degrees. This is the second osteotomy, which we are not doing anything in the beginning. We first do lengthening, then do devalgusization. So at the end of the day, the femur will be of the shape of a Z. It will be grotesque looking in the X-ray, but functionally it will be the best possible outcome. The patient will be pain-free, able to squat, able to sit cross-legged, just like any excision arthroplasty. But patient will be having all this advantage sans the Trendelenburg's problem. So this is the squared pelvis. You can see Z-shaped femur, but stable limb. Another case, infected hip, which was as a result of septic sequelae. So total hip replacement was not possible in this. We did IHR, and you see these are the shunt screws which are at an angle. Now when these shunt screws are brought closer, that 65-degree valgusization will be achieved. You see here, this is the first osteotomy. This is the second osteotomy. Unfortunately, there was some comminution in the mid-facial osteotomy, but still it's not a big problem in Ilizarov surgery. You see these two shunt screws, these two arches are now parallel now. Previously they were at an angle, and after the osteotomy we abruptly induce around 65 degrees of valgus, and all these shunt screws come parallel. Then at the distal level of osteotomy we do lengthening, then we do devalgusization. It's a Z-shaped femur again, but stable without Trendelenburg. This is the final outcome. Patient has a good abduction, good weight bearing with the frame after removal of the frame. This is just before removal. Patient has an excellent outcome. This is another patient. This patient is a complex case. This was operated multiple times. I might have to refer to the notes actually in this case. This is an 80-year-old male patient. This was a fractured neck femur, which was initially treated with an Austen-Moore prosthesis. Then the patient sustained a periprosthetic fracture. An LCP was done. There was some infection post-operatively. There was pus pouring from fracture site with septicemia. There was ICU admission. The plate was removed. The prosthesis was removed. Then the patient underwent antibiotic cement nail implantation with beads. Then debridement and this beads were removed. Now, since we have already a non-union, this is a femoral neck head absent. We have the patient is having excision arthroplasty. It is a girdle stent with a mid-diaphyseal non-union. So anyway, for a PSO, we will be doing an osteotomy almost at around this level. So we make this as an opportunity for using doing a PSO. So we removed the antibiotic cement coated canal and we did IHR. Here, this is the outcome here. You can see the hypervalgus here, and this is the lengthening zone. And at this level, the bone is lengthened and pelvis is squared. This is another case, osteoarthritis hip. Probably an osteoarthritis hip without a confirmed diagnosis. This was opened up for total hip replacement. This patient, when opened, was found to have frank pus inside the stapler cavity. So what does an average surgeon do? He closes the wound and comes out accepting defeat. But if you are an Ilizarov surgeon, what we do is we immediately apply Ilizarov hip reconstruction and give the exact same good result as a total hip replacement and come out like a champion in both situations. So this is the preoperative, this is the postoperative. You can see the initial osteotomy, hypervalgus, adequate pelvic support, and this is the distal osteotomy for lengthening and devulgarization. This is the immediate postoperative weight bearing functional result, and you can see the osteotomy gradually consolidating, lengthening at this zone. The regional rate also is consolidating, the valgus is adequate, and this is the final pelvic support that we achieved. This is another patient, a fractured neck femur, failed fixation with avian of the head with infected implant. So this patient again underwent excision arthroplasty at one another center. This was managed with, this is the excision arthroplasty result. But what we had to offer ultimately was pelvic support osteotomy and give him a stable, functional limb without Trinberg date, with full range of motion of the hip and the knee joint. Another patient, Ilizarov hip reconstruction done with frame on and good result. This is another patient, post septic sequelae, infected head, removed, excision arthroplasty done at another center, total hip replacement was not possible. We did Ilizarov hip reconstruction in our center, and this is the pelvic support, this is the devulgus with lengthening zone, and this is the final result. This is the just before removal, and this is after removal. So there are other applications of Ilizarov in hip region. I will not be covering them today because I don't think there is enough time, but you can use them for even fractures around the hip joint, and you can use it for correction of deformities around the hip joint like COXA VARA, COXA valga, and these we shall cover in some other available opportunity. Thank you for your patient listening, and if there are any doubts, questions or apprehensions, please feel free to interact. I shall be very glad to answer them. Thank you.